beautiful people? Welcome back to my channel. It's me, Kendra, back with another nursing video. I'm going to give you guys a break from the vacation vlogs I've been doing. I hope you all checked out my Grenada vlog and my Miami vlog. I do have one more vacation coming up, so I will be posting a vlog on that. I won't tell you where I'm going. It's going to be a surprise. Anyway, in this video today, I want to talk about rounding in the ICU. With making this video, I specifically have in mind new grad nurses and nurses that are new to specialty. So registered nurses who have experience in nursing but have recently gone into the ICU or is considering joining or applying for the ICU. So let's go ahead and talk everything. As a nurse working in the ICU, one of your responsibilities is participating in rounds. Rounds can take place in the morning or it can take place in the evening. Based on my experience, I noticed that morning rounds tend to be a little bit longer and more in-depth versus evening rounds. It's kind of short, condensed. At times, the providers just kind of go around to each nurse and say, hey, any changes, any needs for the night? If not, call me if you need anything. So what exactly is rounds or rounding? It is when the interdisciplinary team rounds on a patient. What happens is the providers, the respiratory therapist, sometimes the dietitian, case management, a pharmacist, specifically in the ICU, a pharmacist, and of course the nurse round on the patient. They stand usually in front of the patient's room and they go over details related to the plan of care, any issues, and just basically discuss how things are going to go for them. Nurses that are new to the ICU, participating in AM rounds can be very intimidating. It is because you are presenting on the patient, everyone is listening to you, everyone is looking at you. The doctor might have questions about your assessment and you have to be able to answer it. Sometimes I notice that new nurses tend to fumble. They get very nervous. They're like tripping over their words. They're mumbling things. They are speaking very low and they're not making any eye contact. So when I was deciding on what kind of content I want to put out here on YouTube, this was definitely added to the list that I wanted to go over ways to round successfully in the ICU. So basically I'm here just to give you a guide on how to prepare yourself for AM rounds or even evening rounds if your hospital has. I just want to add that dependent on the kind of institution you work in, rounds can be more intimidating for me, especially at like a larger university teaching hospital, because to me, the team, the interdisciplinary team tends to be bigger. Sometimes there's even like physical therapy included in AM rounds. Versus when you round in like a smaller, more rural institution, the team isn't that big, so it's a little bit easier to get through. But that's just based on my experience and my observation. So let's go ahead and jump right into rounds. Getting prepared for rounds is something that you have to do immediately when coming on shift. So for example, you get on shift, you get report. One of the first things you want to do is go in and check on your patient, right? You want to make sure that your patient is alive and well. You want to make sure that everything that you received in report is as what's in the room. For example, if your patient's getting normal saline, you want to check the bags, so on and so forth. As a matter of fact, what I should say is that all of this should be done during report anyway at the bedside, because most hospitals are enforcing bedside rounds or report at the bedside, even though it doesn't always happen. But anyway, your whole goal as a nurse is to be prepared. Prepare yourself for that morning rounds. So you want to go ahead and get your assessment done. Obviously, it's the ICU, so you want to do a really thorough head-to-toe assessment. When you document your assessment, you might also want to jot down some information specifically when it's time to present in rounds. The thing you want to keep in mind is for rounds, you have to be able to speak up. Whispering and speaking in a low tone is not the way to go. Now, I know that your nerves will get the best of you, but you have to do a lot of self-talk. Like you kind of have to build yourself up and say, all right, am I speaking low? Let me raise my voice. Or you can even say, can you guys hear me? Ask them, okay? You want to make sure that you are being heard. Also, too, when you speak in a loud, clear voice, it shows that you are confident. When you're speaking like this and you're whispering, the team is kind of like, all right, like, what's going on here, ma'am? Like, we're doing rounds, get used to it. It's going to happen every single time you work. You can't run from it. You might as well just come in, be confident, speak up, and make eye contact. Another important piece for rounding in the ICU is, as a nurse, you want to familiarize yourself with the proper terminology. Please. This is something I would always tell my nursing students. I would say to them just like this. Let me tell you all something. Familiarize yourself with the proper terminology, because I do not want to hear, when you're telling me about your patient, I don't want to hear, I went into the room and the patient was kind of sweaty. Kind of sweaty? No. What is the proper word for if the patient is sweating? The patient is diaphoretic, okay? So things like when you're presenting in rounds, for example, if you check your patient's temperature and the patient's temperature is 38.3, you don't want to go and say, I think the patient has a fever, the patient had a fever. You want to say that your patient is febrile. So I'm really big on using the proper terminology. I think it shows that you're a professional, it shows that you're knowledgeable, and also it builds confidence in the provider that the nurse caring for the patient is competent, okay? So please familiarize yourself with the proper terminologies. That is one of the best pieces of advice I can give you. Also, when rounding on a patient, sometimes someone can ask you a question. It can be the pharmacist, it can be the provider, it can be case manager. If you don't know the information, and this is across the board in any situation, if you don't know, do not make something up. You can simply say, I didn't get a chance to look at that. Because sometimes rounds happen earlier than expected, or sometimes physicians will switch up on where they're starting rounds. Like some mornings they'll say, okay, we're starting at room 1, and then the next day they'll be like, no, let's just start at room 20 today. And then you're like, what, room 20? I have room 20. I'm not even ready for rounds, okay? It's okay if you do not have all of the information present. It's okay to say, let me check on that and I'll get back to you. Or I was busy with the other patient, I didn't have time to check that, but when we're finished rounds, I'll check it and I'll get back to you. Please, please, please do not make any information up. You also want to have a system in place. Some facilities in their ICUs will have a specific rounding tool, a sheet that you can pre-fill, so that way when it's time for you to present on the patient, you're going in the same format. It's systematic. The physicians they know already what's coming because everyone uses that same tool. So it's pretty much standardized across the board. Now, if the ICU that you're working in does not give you a tool, I am going to give you the key information, step-by-step information that you want to have and present during rounds. So I'm going to give that to you in this video, so make sure that you have a pen and a paper, take some notes, specifically if you are a new grad nurse. Let me just go ahead and add in also that depending on the facility, rounds can happen slightly different. Like I know at the hospital I'm currently at, the nurse is expected to present first. Now, occasionally we'll get a locums ICU doctor who's like, oh, the resident will present and then I'll just ask you questions after. So that kind of relieves you of the burden of presenting. Some other hospitals, the nurses don't present, period. The docs will present and then they'll just ask the nurse, do you need anything? And the information that is required during rounds can also switch up depending on which facility you're at. Like one time during COVID, I took an assignment. It was a 6-week assignment at a local hospital here in Baltimore. And they played with me a whole lot because I was supposed to be in the ICU and they kept tossing me around from all these different units, med surg, tele. I was all over the place. But because I am a nurse and I feel like nurses should be flexible, I was like, you know what? I'm not even going to make no noise. I'm only here for 6 weeks and then I'm out of here, right? One day I went in and they said, oh, you're going to go to the ICU. And it was a cardiac ICU. And I don't like cardiac. Like, y'all could keep cardiac, y'all could keep neuro. Those are not my favorite specialties. So anyway, I went there, got my 2-patient assignment, taking care of the patients, and then it was time to round. So went to rounds now, and they're like, okay, present the patient. Now, I started presenting in the manner that I've always presented in. Then they told me, hold on, you didn't give the whole history. Like, history of admission. Like they wanted me to give the whole story, like the patient came in, what was done in the emergency room, blah, 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 blah. The patient came to the floor, they wanted me to review labs. And I'm like, well, wait a minute. Like y'all are asking for too much. I was not prepared for all of this information. Like I usually just give a quick run through, which I'll show you guys how I run through. But I was like, no, y'all are doing too much. So eventually the attending doctor got pretty agitated with me, and she was like, well, let me just go ahead and do it. Yes, please go ahead and do it, because I was not ready for all of that. Like, am I the one like super overseeing the care of the patient? Like, aren't you the physician? This is y'all responsibility. You want me to discuss labs and discuss this and that? Like, girl, no. All right, are you guys ready? Let's go ahead and go through the format for rounding. Number one, they pull up in front of your room, all the computers are open. I usually say, are you all ready? Because sometimes they're opening the chart, sometimes the workstation on wheels, it's not picking up signals, so there might be a delay. So I always ask, I usually have my paper, because obviously I jot down notes and things like that. So I usually have my paper and I ask around, are you all ready? Now, the way that I present myself, I stand tall, I'm confident, and this is the tone that I speak in. Loud, clear, and I make eye contact always. The first thing you want to address is any significant events overnight. Usually the team wants to know what happened on the previous shift. So for me, I'm a day shift nurse. On the previous shift, night shift, I would say if nothing happened, I would say no significant events occurred overnight. If something significant occurred, obviously I would tell them. Now, what do you consider significant? If your patient became febrile, if the patient had an episode of bradycardia, if the patient had an episode of desatting and had to be taken off the vent and bagged, if the patient lost IV access, if the patient needed to be bladder scanned and straight cath, like all of those things that pertains to the patient care are significant events, or anything that's abnormal that took place throughout the night, you want to bring it up in rounds. Things like the patient was in extreme pain, or we gave the patient 2 milligrams of morphine and the patient braided down and the blood pressure dropped. So things like that you want to bring up in rounds as far as significant events go. So any significant events overnight or any early morning significant events, even if it happened on your shift prior to rounds, you want to bring it up if it's significant enough. The next thing will be the patient's neurological status. By the time rounds is happening, you should have already completed a head-to-toe assessment on your patient, so that way you can discuss the systems in rounds. So the first system you want to talk about is the neurological system, neurological status. Is the patient sedated? Is the patient paralyzed? Is the patient alert? Is the patient drowsy but arousable? Is the patient lethargic, drowsy, difficult to arouse? Is the patient sedated but still wide awake? These are things you want to bring up neurologically. You want to discuss the patient's RAS. Is the patient at a -1, -2? Is the patient +1, +2? How is the patient responding to the sedation? These are the things you want to bring up. What kind of sedatives is the patient on? Is the patient on propofol? Is the patient on Precedex? Did you try weaning the Precedex? Did you try weaning the propofol? How did the patient do? So you want to include all things neurological in the first portion of the systems assessment. You want to discuss exactly how that patient is doing neurologically. Did the patient have any neurological changes? Did the patient decline? Was there an improvement from the baseline? So on and so forth. Does the patient have any abnormal new symptoms that you notice? Is the patient no longer wiggling their toes? Is the patient following commands, simple commands? What did you ask the patient to determine if the patient is following commands? Did you ask them to give me a thumbs up? Was the patient able to follow those commands accurately? So these are things that you want to talk about in rounds. Next step is respiratory. Is your patient intubated? If the patient's intubated, is the patient on the vent? Well, obviously, the patient's going to be on the ventilator, right? Sometimes though, this can be a little bit tricky because usually the physicians or the providers will refer to respiratory for this section. So I still talk about respiratory. Sometimes I do not give vents. I don't think I give vent settings. I leave that for respiratory to do unless respiratory isn't present because they had to go off the floor or they had to deal with an emergency. I'll include the ventilator information. But I talk about sputum production. I talk about whether or not my patient is coarse, lung sounds, how much secretions am I getting back. Let's just see, is the patient O2 sats greater than 92%? Or is the patient sat in 90, let's say 85%? Is the patient desatting when we reposition the patient? I'll just include all things respiratory at this point. Next up, we want to talk about cardiac, okay? Patient is sinus rhythm. Does the patient have any edema? Does the patient have palpable pulses? Has the patient been normotensive or has the patient been febrile? I'll include that in this information. While I'm in the cardiac section, I'll go ahead and I'll talk about the patient IV access, invasive lines that the patient has. Does the patient have a central line, a PICC line, a midline? Does the patient have peripheral access or does the patient have no access at all? These are things you want to bring up when you're in the cardiac section. What drips are the patients on? Are the patients on any cardiac drips? Did you reduce the drips? Did you have to go up on it? How is the blood pressure? Are we meeting goal? Is the systolic goal, is the patient at the systolic goal or are you not meeting goal? Did you have to intervene and give any of the PRN blood pressure medicines that's on the patient's MAR? So these are things that you want to bring up in rounds as far as cardiac is concerned. To piggyback on cardiac, you also want to discuss, don't forget A lines. Does your patient have an A line? Where is the A line located? Is the A line correlating with the cuff pressure? Did you have trouble with the A line? So just don't forget that if your patient has an A line, you want to talk about that as well. Also, while we're on the topic of access as far as peripheral IVs go and central line goes, you also want to talk about if your patient has any ports. Does your patient have a dialysis access? All under cardiac. Of course, we move on to the GI system. This is where I discuss the patient's last bowel movement. Is my patient having bowel movements? Is the patient on a bowel regimen or am I requesting that the patient be placed on a bowel regimen? These are all things as nurses we have to bring to the attention of the providers during rounds. Was the patient last bowel movement prior to admission? Has the patient verbalized the need or the feel to go to the bathroom but it's been unsuccessful? How about tube feeds? Is the patient on tube feeds? Is the patient tolerating the tube feed? Did you check residuals? Were the residuals high or were they like minimal? Now I know some places are saying that we don't have to check residuals. However, I was trained to check residuals, so I check residuals. Did the patient have any vomiting? Did the patient complain of any nausea? Let's see, what else GI wise? If the patient is not an intubated patient, not on a ventilator, is your patient on a diet? When the diet tray comes, is the patient appetite up to par? Is the patient eating at least 50% of all the food or 100%? Or is the patient not touching the meal at all? Is your patient needing to have a supplement added to their meal like Ensure or Boost or whatever? Because some patients have that regimen at home and we might need to alert the dietitian during rounds like, hey, the patient takes Boost, whatever, daily with meals. So this is something you want to bring to the attention of the dietitian. Let's see, what else GI wise? Oh, does your patient have any invasive feeding tubes? Now, not a PEG tube, not the surgically paced tube that goes into the abdomen. I'm talking about OG tube or NG tube. If it's an NG tube, we need to start finding out, okay, how much longer are we going to keep this NG tube in? Do we need to switch the location of the NG tube due to skin breakdown? So these are things that you want to bring up during rounds as far as the GI system is. And I'm trying to see if I'm missing anything because as you can tell, or maybe you can't tell, I might be that good, that I'm doing this off the top of my head. We're moving on right now to the GU system. You want to talk about the patient's urine output. Is the patient having adequate urine output? And we know adequate urine output is what? At least 30 mLs an hour. Or is your patient a dialysis patient? If your patient is on dialysis, is the patient anuric or is the patient oliguric? The patient, let's see, does the patient have an indwelling Foley catheter? Is it a suprapubic catheter? Does the patient have nephrostomy tubes? Do we still need the Foley catheter? Is it a chronic catheter? Did the patient came in with this catheter from home and requires it? Is the catheter placed by urology, meaning that only urology can insert the catheter? Or should we remove the catheter, being that urology is the one that inserted it for a reason? So there's a lot of things in the GU system that you want to be reporting to the physician. Things like, did the patient have any urinary retention? When you bladder scan the patient, did the patient have like, you know, urine sitting in the bladder that you had to intervene? Or do you need an order for like intermittent straight cath? Does the patient have a condom catheter? Can we remove the Foley catheter and replace it with a condom catheter? So these are all things that you're also presenting and like bouncing ideas when you're in rounds as far as the GU system. Of course, we're going to touch on the skin. Does the patient have any open wounds? Did you notice any new breakdown? Do you think that the wound is getting better, or has it gotten worse? Does the wound have a foul odor? Has the wound nurses been consulted to see that wound? You also want to talk about, I forget to mention this in the GI section, does the patient have an ostomy? Is the stoma pink? Is the patient having the adequate output from that ostomy? Same thing for GU. Some patients have a urostomy. So you want to make those things clear during rounds, because I'm going to tell you this. Sometimes, especially if it's a change in the attendant, like it's a new attendant on for the week with a new set of residents, sometimes they don't have all of the information as far as the patient's assessments go. You're the nurse, you're the one that kind of gatekeeps the assessment and what's going on with the patient day to day. So you are sometimes bringing the team up to date and keeping them abreast on what's going on with your patient's assessment status. Now, sometimes during rounds, you might say something about a specific system and someone might refute that claim. They might say, no, when I went in there, this is what the patient said. And it's kind of like, okay, but you already know that your assessment is your assessment, right? If you assess your patient properly and that is what you got for your assessment, don't have anyone else tell you different, okay? Once you've done your due diligence. Another thing that might come up in rounds, they might ask you, based on the patient's current status, does this patient still need to stay in the ICU? And as a registered nurse working in critical care, you have to be able to back up your claim. You can say, you know what, I no longer think this patient require ICU level of care. The patient can probably go to med surg or go to like an IMC unit or go to step down tele. Sometimes the physician might say, you know what, yeah, let's go ahead and transfer the patient out. And as a nurse, you might say, doctor, I think we're kind of rushing it. Maybe we should keep him just a couple more hours or keep him one more night just to kind of see what's going on, because this is what I've noticed or this is what I was being told. And sometimes the docs might say, hey, you know what? Okay, fine. You're the nurse. You're the one at the bedside. You know this patient better than I do. We'll keep the patient for a few more hours, maybe one more night, and then we'll reassess in the morning or we'll reassess later. Rounds, especially in the morning time, is also a good time to bring up any social issues you might have learned about with this patient. For example, sometimes you might learn the patient is homeless or the patient lives at home alone. So you want to start like putting that out there so case management can start tracking to plan for discharge, right? Because we know discharge planning starts from the moment the patient gets admitted to the hospital anyway. But as the nurse at the bedside, especially if your patient is not intubated and sedated and they can communicate with you, I always make it a habit to talk to my patients about their social situation. Like one of the most popular questions I ask is, who do you live at home with, or who lives with you at home? And sometimes I learn that this patient is going home to no one. Or I'll learn things like, yeah, my lights are off, or I don't have running water in the house. So all of these things needs to be brought to the attention of the social work. The patient might have concerns about safety. Patient might have concerns about, let's just say this patient now has been in the ICU for like 2 weeks and they're much weaker than they were prior to coming in, but this patient is also on dialysis and they have to go to an outpatient dialysis center for treatment, but they're so weak, you now might need to bring to the attention of the team that, hey, this patient's on dialysis, but this patient is super weak, he requires 2 to 3 people to get out of bed. Then that might trigger a physical therapy consult, so that way we can plan possibly for like a rehab stay to get the patient stronger in order to then transition the patient back to home. So rounds for me is a very important, crucial time. Early in the morning when you come in, try and get to know your patient as much as possible. That way during rounds you can bring up any issues that you might have found out, or anything that the patient or even the family might have brought to your attention that needs to be. Times where I dread AM rounds, I'm just like, I don't want to do it. Like, I just don't want to stand there and wait and listen to every single thing. I'm tired, I want to sit down. But you know what, rounds are very important, especially in the critical care area. This is when you get to be a part of the patient's plan of care, in planning for the patient, in formulating how things are going to go for the day. This is when you learn a little bit more about the patient. You learn what testing the patient's going to go for. You hear what labs are going to be ordered. So that way you're making a mental note. And there are times where I will even jot things down on my report sheet, like on my little to-do list section, on all of the things that I heard in rounds that need to get done. So immediately when rounds are over, I get straight to work. Another thing that I love about AM rounds, especially when you're in a teaching hospital and there are residents participating in rounds, there's a lot of teaching that happens. And I have learned a lot about patho and just overall patient care, and even medication, because the pharmacist is there and they're doing a lot of education, because of course it's a teaching hospital and the residents are there to learn, to put everything that they learned in medical school into practice. So as a nurse, I usually stick around and I listen and I'm like, okay, that makes sense. Like, I learned a lot during rounds. So I hope that this video was useful. I hope that it added value, and I hope that any new grad nurse or any nurse transferring to the ICU will find it useful. I really wish I had a rounding tool present. Like, I really had a good one, but I don't know. I don't use it anymore because I have my format in place. I kind of know exactly what I am going to address in rounds. And I'm going to tell you this, the more and more you participate in rounds, the more you get better at it. Just be confident. Like I said, speak clearly, speak up. If you don't have the answer to any questions, don't make anything up. Just say, hey, listen, I didn't get there yet. I will get back to you all. And overall, just, you know, show up to work looking good, look presentable, make sure your scrubs are neat, your hair is done, you know, and just go ahead and present that patient. Anyway, thank you all for tuning back into my channel. Thank you for watching my videos. Please, if you all can go over to TikTok and follow me on TikTok as well. My account is KenJenRN. I've had this account for a few months and it has done a lot of growth, and I want to continue to grow it because TikTok is cute for like a little quick fun video. But anyway, y'all, thank you for watching. I will see you all again in the next video. Leave me some comments if I missed anything out, and also to add any information in the comments, so that way any new grad nurse, a nurse considering to go to the ICU, can go ahead and get some more information from the comments. See you all.